Hello, my name's Arif Khwaja. I'm a nephrologist at the Sheffield Kidney Institute. Welcome to this first lecture in a series of lectures on CKD MBD. And what I'd like to do in this first lecture is just introduce some very simple concepts about mineral metabolism in health and CKD. This will be very basic and very familiar to many of you, but for some of you it may provide just a bit of useful revision as to why CKD MBD and the mineral disturbances in mineral metabolism we see in CKD can be so harmful. So they're just some very key concepts that I just want to introduce, which I think you're all very familiar with. There is a complex interaction between calcium, phosphate, parathyroid hormone and vitamin D in CKD MBD. And parathyroid hormone tightly regulates calcium levels. That's in health. Phosphate, the main source of phosphate in health is from the diet, and phosphate is predominantly excreted in the kidneys. And as you know, vitamin D is activated in the kidneys. Fibroblast growth factor, and I'll talk about this later, is a key regulator of phosphate homeostasis. It's a phosphaturic hormone, like parathyroid hormone. It increases the excretion of phosphate from the kidney. Dietary phosphate and serum calcium increase FGF-23 secretion from the osteocytes, and we'll talk about FGF in a while. And FGF-23, as I said, not only increases phosphaturia, so increases phosphate excretion from the kidney, it reduces vitamin D activation and it reduces parathyroid hormone as well. So if we just look at the kind of overview of changes that happen in CKD as your GFR declines. So as your GFR declines from 90 down to 15, you can see in green here, the PTH starts to rise from around 50 to 60 onwards very gently, and then you get a steep rise once you get to CKD4. The phosphate rise tends to occur a bit later because you remember PTH, as PTH rises in CKD, it gets rid of phosphate from the urine, so phosphate tends not to rise until fairly advanced CKD, sort of towards advanced CKD 4 and 5. FGF-23 is a phosphaturic hormone like PTH, and that rises progressively as your kidney function declines, and it's not clear what the trigger for FGF-23 is in terms of why when your kidney function declines FGF-23 increases. As I've said already, if your kidney is not able to hydroxylate vitamin D, then your hydroxylated levels of vitamin D will fall as your kidney function fails. And Klotho, which we'll talk about later, as your GFR declines, Klotho, which is a soluble receptor for FGF, a co-receptor for FGF-23, soluble circulating Klotho declines as GFR declines as well. So let's just talk a little bit about vitamin D, because there's a lot of confusion about vitamin D. So in health, vitamin D can be, a source of vitamin D can be in the diet or from the skin when UV light shines onto your skin, and that leads to the generation of vitamin D3 or cholecalciferol, vitamin D2 from the diet, which is ergocalciferol. Okay, those two forms of vitamin D are then hydroxylated in the liver, and that's the main circulating metabolite, 25-hydroxy vitamin D, and that's what most of us measure when we measure vitamin D levels. Okay, this is then 1-hydroxylated, as you're aware, in the kidney. But you also, very importantly, you get some extrarenal hydroxylation within the cells. You get autocrine and paracrine effects as well. So as well as renal 1-alpha hydroxylation, you get extrarenal 1-alpha hydroxylation, finally leading to the generation of calcitriol or 1,25-hydroxylated vitamin D. I would suggest you pause this slide for a second and just look at the terminology of vitamin D, because it is quite confusing. cholecalciferol and ergocalciferol refer to the native forms of vitamin D produced either in the skin or from the diet. They're not interchangeable. It was thought they were, but they have different pharmacokinetics. And then the 25-hydroxyvitamin D can either be 25-hydroxylated cholecalciferol, so that's calcidiol, or 25-hydroxy ergocalcidiol, which is 25-hydroxylated vitamin D2. And then that's then activated to produce calcitriol, which is the natural activated vitamin D. Of course, we give vitamin D receptor agonists such as alpha-calcidol, which is a synthetic prohormone, so that's one alpha-calcidol, so that's one hydroxylated vitamin D3, or we give other vitamin D receptor agonists such as paracalcitol, maxicalcitol, and doxoricalciferol, which are vitamin D2 or D3 synthetic analogues. So just worth pausing that slide for a second, just so you're familiar with the terminology. So let's just talk a little bit about kind of mineral metabolism normally. So parathyroid hormone, if you have a low calcium, that stimulates the parathyroid hormone to produce parathyroid gland, to produce parathyroid hormone. As you know, that has an effect in health on the bone, leading to release of calcium and phosphate from the bone, and also leading to increased calcium reabsorption from the bone and increased phosphate excretion from the kidney. And it also acts on the kidney to increase calcitriol production, and all of those will tend to normalize your serum calcium. Okay, that's a normal physiological effect. So in chronic kidney disease, of course, you're failing to activate vitamin D, so you become hypocalcemic, and that leads to elevated in PTH. You're failing to excrete phosphate because your kidney is not able to get rid of the phosphate. That leads to elevations in PTH. And the elevated PTH will increase phosphate reabsorption from the gut, and you can't get rid of it in the kidney, so that will lead to increased phosphate. And the elevated PTH will increase bone mobilization of calcium, leading to increased serum calcium. And there's relative resistance in the parathyroid gland to FGF-23. So this is a kind of pictorial overview of what happens in CKD. So you can't get rid of your phosphate in advanced CKD because you don't have enough nephrons. So that leads to a rise in plasma phosphate, hyperphosphatemia. That may bind a bit of calcium, leading to a sort of lowering in serum calcium. That stimulates the parathyroid gland to produce PTH. And that PTH leads to increased calcium absorption. But of course, you can't get rid of the phosphate excretion because the kidneys, you have less nephron mass. Increased calcium resorption from the bone, leading to hypercalcemia and causing renal osteodystrophy, and activating vitamin D to increase calcium and phosphate reabsorption from the gut. So when you've got kidney disease, you can't respond to the higher parathyroid levels, so the phosphate levels remained high, and you get this vicious circle of secondary hyperparathyroidism. Let's talk a little bit about phosphate balance, just in health really. So you normally ingest around just over a gram, 1.2 grams of phosphate in food, and you excrete about 400 milligrams every day in the feces, all right? And the rest is absorbed and associates in various pools, whether it's the bone, the cardiovascular system, but most of it is excreted within the kidney. So you can imagine if you block this excretion in the kidney because your kidneys aren't working, the phosphate's got nowhere to go other than perhaps the cardiovascular system. And indeed, as you know, hyperphosphatemia is a big driver of vascular calcification. And that's shown here in this slide that these show the kind of potential mechanisms by which phosphate can increase vascular calcification. This may be due to sort of calcification of the extracellular matrix in the blood vessels. The smooth muscle cells effectively assume a bone-type phenotype. So your vascular smooth muscle cells become like bony cells. Okay, you'll hear a lot about FGF-23, so let's just give you some sort of key facts about FGF-23. It's obviously, as I said already, it's a key hormone involved in phosphate homeostasis. It doesn't directly affect calcium homeostasis. It's a peptide that's produced mainly by osteoblasts and osteocytes, and it's secreted in response to dietary phosphate. It's a phosphaturic hormone, so it increases urinary phosphate excretion. It inhibits vitamin D activation in the kidney, and it may have a direct effect on the heart, leading to left ventricular hypertrophy. And why is FGF-23 important? So if you look at patients on dialysis, and if you look at their levels of FGF-23, the higher the levels of FGF-23, the higher the risk of mortality. So how does FGF-23 signal? So the FGF-23 is released from the bone, the osteocytes and osteoblasts, and acts predominantly renally in the renal tubules. Okay, so it binds to the FGF-23 receptor, but for FGF-23 signaling to take place, you need the presence of this transmembrane protein called Klotho. Okay, so Klotho is absolutely required for FGF-23 signaling to take place, and the kidney is an important source of Klotho in the systemic circulation. So as I said, FGF-23 is not only phosphaturic, it increases the phosphate excretion by inhibiting a sodium phosphate transporter in the proximal tubule, so that leads to phosphaturia. It's also calcium and sodium conserving by increasing calcium and sodium reabsorption from the distal tubule, and it also has a direct inhibitory effect on the activation of vitamin D. Okay, so those are effects on the kidney, but as FGF-23 rises, there are inhibitory effects on the parathyroid hormone, but also there's increasing evidence that FGF-23 may be, in animal models, directly cardiotoxic, may induce left ventricular hypertrophy, and toxic to the blood vessels as well. So if you knock out FGF-23 and if you knock out Klotho in animals, the animal in rats, they die from premature aging. So Klotho was in fact originally thought of as an anti-aging factor, and they die because of excessive vitamin D signaling, leading to excessive vascular calcification. What about Klotho? So as we've talked already, as Klotho as being this receptor, not receptor, but a transmembrane protein that sort of associates with the FGF-23 receptor that enables phosphate excretion to take place from the proximal tubule and calcium reabsorption to take place from the distal tubule. The kidney is an important source of circulating soluble Klotho, which may have effects on insulin signaling in the muscle and the adipose tissue, and may also have protective effects on the vascular system and the heart. So if you reduce your serum Klotho, that's potentially a mechanism by which so you get reductions in serum in soluble Klotho in kidney disease, and some have postulated that may be a mechanism by which you see the increased cardiovascular morbidity and mortality in patients with kidney disease. So just an overview, again all very complicated really, but just to show that you have a complex interplay between FGF-23, vitamin D, calcium, parathyroid hormone and phosphate, and they have inhibitory and stimulatory effects on each other. I'm not going to talk your way through it because it's fairly obvious, but it might be worthwhile pausing your slide so you can see that vitamin D may stimulate FGF-23, it may inhibit PTH, but obviously increases serum calcium. Serum calcium, their levels are high, will inhibit PTH. PTH levels, if they're high, they will increase serum calcium, etc. So you can see that there's a really complex interplay between all these factors. So just to summarise, in health, calcium phosphate homeostasis is tightly regulated by PTH, vitamin D and FGF-23. And in CKD, there's ultimately a failure to activate vitamin D. You're unable to excrete phosphate excretion by the kidney, and there's resistance to the effects of FGF-23 because you have less nephron mass, so the FGF-23 can't exert its phosphaturic effect. neither can the parathyroid hormone, and you get this vicious circle of hypercalcemia, hyperphosphatemia, and hyperparathyroidism, all of which, as we touched upon, may increase the risk of vascular calcification. Thank you for your attention, and we'll cover some of these concepts and the clinical relevance in the other CKD MBD lectures.